All right. Well, hello, everyone. We're so glad that you are maybe back with us from the previous episodes, or maybe this is your first time attending one of the PBIC Health and Transportation webinars. But we are now up to part 3 of our 5-part Health and Transportation webinar series. We have an excellent panel here today to talk with us about continuing the topic of health and transportation, but really talking deeply about integrating health data and transportation data, getting health data into transportation planning and really utilizing that valuable source of information and data. And we're going to hear a lot about that today, some different stories from our panelists who I'll introduce shortly. But before we do that, what I wanted to take a moment and do is just center you all on some housekeeping items and let you know what you can expect today in this webinar. So first, your attendees, so you won't be able to actually speak up during the webinar, but you do have the ability to submit questions and comments along the way. You can do that in the questions pod, and I'll be monitoring that, and we'll share those questions with our panelists when we've held about 25 or 30 minutes at the end of the webinar for a Q&A period, discussion period. So please send those in at any time, and that's when we're going to hold those for at the end. We are archiving the webinar. We posted a PDF of the slide presentations. That's already up on our website. We're also going to be posting a video recording of the webinar. So if you miss anything, or if you know someone who wasn't able to make it, you'll be able to watch everything again once it's up, probably sometime tomorrow morning. That'll be available. We're providing certificates of completion to everyone following the webinar. That'll come in a follow-up email later today. That'll demonstrate, you've done the hours, 1.5 hours for this webinar, and hopefully you can use that to self-report those PDHs and other things. We've gotten the webinar approved by the American Institute of Certified Planners for 1.5 CM credits. That's up on their calendar, so you can claim those as you usually do if you're a planner. I mentioned the follow-up email later today. That'll have some resources in it, a link to the archive page, a link to the certificate that you can complete, and a few other things. So keep an eye out for that. It should come to you 1 or 2 hours after the webinar is concluded. I'd encourage everyone to just check out the previous episodes in the series. If you missed them, we've done parts 1 and 2 already. They're on our website. Here's a list of what we've got planned, what we've done, and then obviously today integrating health data. And then another couple of episodes next Tuesday and Wednesday on prioritizing projects with health in mind, and then bringing health to the transportation policy table. At the end, that's going to really be a whole wrap-up discussion period for kind of concluding the webinar series. We know obviously that health and transportation intersect in many ways, but I think we can always be thinking about doing a better job in our work as maybe professionals or advocates or those in transportation or in health to kind of bridge that gap and reach across to those other organizations that are doing this work and really do a better job kind of elevating and integrating health into the transportation work we're doing. We are motivated in part to do this series by a project from NCHRP, which you'll see there on the screen, Research Report 932, which raised some questions about, how are we incorporating health and equity and defining those within transportation work, and how can our practices in transportation impact health? What are ways in which transportation agencies are considering health in their practices, and how can we tap into partnerships, research, and other resources to really improve the way we're doing this? So we're trying to answer some of these questions in this series, thinking through pathways to health that we may be aware of, and really bridging gaps as we see them between transportation and health agencies. And so what I would encourage everyone to be thinking about is kind of how your work ties in, whether you're in transportation, how health may be impacted in the work you're doing, or vice versa. As we get into today's topic, which is really going to take a close look at data, and our panelists all are well versed in data and health from their perspectives and their backgrounds. And so what I'd like to do now is introduce each of them to you and tell you a bit about their experience. We're first going to be joined by Ann Dellinger, who serves as Chief of the Applied Sciences Branch of the Division of Injury Prevention at CDC's National Center for Injury Prevention and Control. There she oversees the work of the center in several topic areas, including transportation safety, traumatic brain injury prevention, suicide prevention, and older adult fall prevention. So we're lucky to have Ann with us today, who will be kicking things off and serving as our moderator. So thank you, Ann. Leslie Meehan is also with us. She oversees the Office of Primary Prevention in the Commissioner's Office of the Tennessee Department of Health. The office serves as a hub for upstream primary prevention policies and strategies that impact social influencers of health. Her work includes increasing physical activity through the built environment to positively impact social, emotional, and physical health. Previously, Ms. Meehan served 10 years as the Director of Healthy Communities for the Nashville Area Metropolitan Planning Organization in Tennessee. At the MPO, she focused on the intersection of transportation and health, specifically transportation's impacts on physical activity, air quality, and injury. So thank you, Leslie, for joining us today. Katie Harmon is a research associate at the UNC Highway Safety Research Center. Katie holds a PhD in epidemiology from the University of North Carolina at Chapel Hill, an MPH with a joint concentration in epidemiology and environmental and occupational health from St. Louis University, and a BS in environmental health science from the University of Georgia. Katie is also a graduate of the CDC CSTE Applied Epidemiology Fellowship Program. We're lucky to have Katie with us today. And finally, Shamsi Soltani is a Vision Zero epidemiologist for the city and county of San Francisco. She coordinates a probabilistic linkage of police traffic collision data with hospital trauma and emergency transport data, creating a comprehensive transportation injury surveillance system. The TISS informs San Francisco's high injury network and guides capital investments in city infrastructure. She additionally collaborates on various projects concerning equity and health, from tracking the burden of injury on the most vulnerable road users to advocating for national data on micromobility related injury. So we're so lucky to have all of these panelists here with us today. I don't want to take any more of their time, so I'm going to go ahead and turn my screen over and the floor over to Ann Dellinger. And Ann, I will let you know when I've got your slides up and running. Perfect, you're all set.
Great, thank you. So good afternoon, everyone. It's a pleasure for me to be here today to tell you a little bit about CDC and to moderate this session. When I tell people I'm from CDC, they don't think of injury or transportation or any of the things that you and I might do. They think of infectious disease and whatever's on the news at the time. So that's COVID-19 or the flu or Ebola or E. coli. But when I think of CDC, I think of the words on this slide. I think of public health and injury prevention and being data-driven and measuring burden and conducting applied science, evaluating our programs and being strategic so that we can make the largest impact possible. There we go. But before we get started, I wanted to just take a minute to talk about a colleague who we lost earlier this year, Chris Katichki, who I think that many of you know in this field. So I wasn't really sure how to do this. So what I decided to do was to pull words off the memorial page at CDC, and then I made a word cloud with the words that people were using to describe him and how much they appreciated knowing him. So this is what was said. Mostly people noted his kind and generous spirit and his dedication and passion were a constant inspiration to others. He was a joyful person with a great sense of humor and really a champion for access for people with disabilities. Quite telling for our purposes here today, he served as a connector and a bridge, and it was really interesting how many times people use those two words to describe him and his work. And then at the bottom there, I just put, if you're interested, there's a memorial fund set up by the CDC Foundation in his honor, and aptly, it's called Bridging Urban Planning and Public Health. I was going to stop here in case Leslie wanted to say a few words.
Thanks so much, Ann. I can only echo the sentiments on the screen about Chris. He was an early adopter and a champion for equitable communities. And it's hard to be in that space when, particularly more than a decade ago, there weren't many people thinking along the lines as he was. And Chris was not only kind, but he had a sense of grace about him that made him everyone's friend. He was a kindred spirit, and he was able to translate this work into messages that resonated with everyone. So he was a true mentor and an inspiration for my career.
Thank you. Thanks, Leslie. Okay, so to get started, I'm just going to give you a few minutes on CDC and what we're doing in this area that we're speaking about today, which is data linkage or data integration. And so what we're going to speak about today resides in the Injury Center at CDC in the Division of Injury Prevention. There's 3 divisions in the center, one on overdose prevention, one on violence prevention, and then we are the Division of Injury Prevention. And so within the injury, we have a transportation safety team, and the priority areas for that team are restraints, which is belts and child safety seats, impaired driving, which is alcohol and certainly other substances, older adult mobility, and data linkage. And then I'm just going to give you a few examples of some of the data linkage work that we've been doing over the last few years. The first thing that we did was a collaboration with NHTSA, this evaluation of data linkage systems, where we surveyed 28 states and asked them about their data linkage systems, what went well, what didn't go well, and then published this report. It was right around the times that the codes project from NHTSA was going out of existence, so that tells you it was just a few years ago. Our more recent publication is this Links Guide, and that's a kind of a state how-to guide. I'll tell you a little bit more about that for non-fatal crash surveillance. So what does the Links Guide do? It helps states start or expand their data linkage program if they already have them. It presents key components of successful linkage programs, and then it explains each step of the process. So when I say how-to, it really is a how-to guide. And so we based it on best practices and lessons learned from successful programs, an environmental scan for data linkage research, and then some state data linkage pilot efforts. Okay, another thing that I wanted to tell you quickly about was our work with the National Governors Association. And we've done learning labs with them, which is a very interesting process. So the National Governors Association brings small teams together so that they can develop a state plan to really improve access and data sharing and analysis, and really use the data to give decision makers something to go on. So there were data linkage learning labs in Maryland, and they brought the states together that you see there: Colorado, Connecticut, Louisiana, Maryland, Minnesota, Utah, and Washington. So that was quite a big group. And then there was also a data linkage learning lab in Utah that brought Illinois, Kentucky, Tennessee, Vermont, and Virginia together. Another thing that we did was, if you're familiar with the core injury and violence prevention program at the center, we fund states to do injury prevention programs. And so what we were able to do was fund 4 states with some supplemental funding: Colorado, Illinois, Massachusetts, and North Carolina, to do data linkage. And it's a 2-year program. This is their last year. First year, using data linkage methods and software to combine their data. And then this year, really analyzing the data to identify risk and protective factors, and then the outcomes for the non-fatal crash injuries. And I think the last thing I was going to mention was our Injury Center extramural research. So for us, extramural means money that goes out the door to outside researchers. And so we're funding 4 groups of researchers to probabilistically link hospital and crash data. In particular, this one is to understand motor vehicle crash outcomes among older adults, And we have 4 states represented there: Utah, Maryland, Kentucky, and Ohio. So the main focus is to assess older adult crash injuries, factors related to injury severity, and then costs. And that research will complete this year. So with that, I think it's great to have you all here, and thank you, and let's get started.
Thanks so much, Anne. Great kickoff there. I'm going to hand the screen now over to Leslie to continue on with our presentations. Great, you're all set, Leslie. Oh, you're still on mute though. Sorry, I just noticed that.
Thank you. Thank you so much, Anne. And Tennessee has certainly been able to benefit from the work of your office, and we greatly appreciate the data linkage that has been able to happen between our Department of Health and the hospital discharge data and crash data from our Department of Safety. So moving forward, there we go. Building on the comments made about Chris and how he was such a fantastic bridge builder, this is really the premise of the work today. And as Anne said, in public health, there are a lot of charges that we have. We have a lot of work that we do in a variety of areas, infectious disease certainly, but really a lot of it is focused on chronic disease and drilling down to quality of life. And today we're talking a little bit about how do you build those bridges between transportation and health and have meaningful data linkages. And this is the premise that we've been operating under for more than a decade, that our streets should be public assets. And when you look at this picture, and if I'm speaking with public health professionals, we talk about the scene and we dissect that there are limited sidewalks, no bicycle lanes, there's a prevalence of fast food, predatory lending, even the signs and the wires. And this is not all happenstance. This is all because of either a lack of good policy or poor policy that's in place. And so what we hope to do is help public health professionals understand that they can advocate for better health outcomes through the transportation and the land use planning processes. This is some data that we charted first back in 2008, where we looked at the adult obesity rate that the CDC tracks, and we went back to 1960. And we also looked at the amount of miles that we drive as a nation, or vehicle miles traveled. And when we charted these two, we noticed some similarities. We weren't necessarily saying that there was direct causation, but we felt that this was something that we should be paying attention to, that our driving habits certainly appeared to be impacting our health as a country. For about 10 years, I worked as a transportation planner for the Nashville Area Metropolitan Planning Organization, which is centered in and around the Nashville region. It's home to about 1.7 million people and was predicted to almost double in size over the next 20 years. What we did was to make sure that we put public opinion at the forefront of our policy. We did a survey of 1,100 households, and we asked folks, among a variety of questions, what would you do? How would you spend the money if you were in charge of the purse strings? What we heard is the first choice was to improve and expand mass transit. The second choice was to make communities more walkable and bike friendly. And the last choice was to build or widen existing roadways. This was really important data, not only from urban areas, but very much suburban and rural areas, but we shared this with the elected officials who are the decision makers for the MPO. And these were the opinions of their constituents, so this information was very important to them. And we translated this directly into public policy. Metropolitan planning organizations, for those who aren't familiar with them, are in every urbanized area in the United States with a population of more than 50,000. And their charge is to allocate federal transportation dollars and to work with local governments to determine where those dollars should be spent. They are charged with creating a policy document that must be updated every 5 years. And so for our plan that had a horizon year of 2035, we wanted to make sure that we were putting forth mass transit and walkable communities, and then preserving our existing roadways rather than building new ones as our 3 policy tenets. In order to back up this policy, we created new project scoring criteria. And you can see that the vast majority of the points, both in the 2035 and then 5 years later for the 2040 plan, really centered around complete streets, smart growth, Vision Zero type principles. So we were putting multimodal options first, health and the environment, safety and security, managing congestion with ways other than widening roadways. And this really flipped the paradigm in our region. Before, we had primarily new road or roadway widening projects that were submitted for consideration. But based on this scoring criteria, our several dozen local members who are the city and county governments realized that in order to be competitive for funding, they needed to think more along the lines of providing transportation options for all users. We also wanted to make sure that we were prioritizing around health. And being a transportation agency, we didn't know if we could get health data at a micro level. And because we couldn't, we turned to census data. And we roughly knew that areas that were at or below poverty, were minority and or had populations over the age of 65, translated into populations that experience higher rates of health disparity and chronic disease. And so we overlaid those areas, and that's the area you see on the screen in red. And we wanted to make sure that we were prioritizing transit options, walking and bicycling facilities in these areas to not only provide transportation options, but opportunities for healthier lifestyles. We created several other evaluation tools. We created a bicycle pedestrian level of service tool. We calculated bicycle pedestrian latent demand. So those would be bicycle or pedestrian trips that could happen if the infrastructure was in place. We were looking at where we had congested roadways and how we could alleviate congestion again with other ways other than road widening. We looked at bicycle pedestrian crash data, and we combined all of that with that health priority area data from the previous slide. And what we created were composite priority areas for this 7-county region. The blue area is the bicycle priority areas, and the purple map shows the pedestrian priority areas. And so when you drill down to specific corridor level projects that were submitted for funding consideration, we were able to look at a data score that helped us to see how all of those factors came into play. And if a project was submitted, let's say, without a sidewalk or a transit amenity, but was a high priority area, we were able to go back to that particular city or county and talk with them about how to amend their project to better serve more users. And then for the funding strategy, we made sure that 70% of our funding was going to go to roadway projects that were improving health. And then we took the additional 30% and we broke it down in a few other programs. We wanted to add additional dollars to active transportation since it had been underfunded for so many decades. So these could be infrastructure or non-infrastructure projects. We also added 10% to dollars that we were already receiving from the Federal Transit Administration, and this allowed us to, again, add more funding to an area that had been under-resourced. And finally, we were looking at investing in technology so that we could make systems flow more efficiently without having to build infrastructure. The result, as you see in the bottom of the screen, when I came to the MPO, we had just adopted a 2030 plan. And again, that's got a 20-year planning horizon. And so only about 2% of the projects had any sort of active transportation element. After the first and second iterations of these scoring and policy changes, we were able to fund up to 77% of the projects that were more of a complete streets type approach. And you can see that in a short 5-year period, we had quite a significant increase in sidewalks, bikeways, and greenways in our region. Another project that we did was a household travel survey. It was the second survey of its kind in the country that included health data. All participants answered basic questions about their height and weight. We had 11,000 participants. There we go. Height, weight, time spent getting physical activity, the average time they estimated they spent sitting, a self-assessment of their diet, and a self-assessment of their overall quality of health. We worked with the CDC and our consultant partners, actually UNC and a few others, to help craft these questions so that we could get the transportation and the health data that we wanted from the 11,000 participants. We also conducted a sub-study with several hundred adults who wore GPS units and accelerometers for several days, and they answered more intensive questionnaires about the prevalence of chronic disease burden, mental health, food security, et cetera. All this data was very helpful for us to be able to paint a picture of the transportation network in our region, and more importantly, the impact that that network and those trips had on the lives of the residents in our region. So based on that data, we were able to update those health priority areas, and whereas before we had to use census data, now we were able to use the self-report data, which correlated with households that were, again, in poverty, experienced unemployment, were carless, or over age 65. So what we found is that the best guesses we had using the census data a number of years prior were actually pretty close to the attributes of households that were self-reporting poor quality of health. We then took that data and we worked with a researcher in the UK and the city of San Francisco who had piloted something called the Transportation and Health Impact Model. And again, in partnership with the CDC, we were the second application of this model in the country. And it is a scenario planning tool. It lets you look at how much physical activity would you like a population to have because of active transportation. So it could be walk or bike alone, or in conjunction with a transit trip. And so we created several different scenarios. And in one of our scenarios, I'll show you the results in a moment, the findings were pretty significant. But for those who would like to see what does the model take into account, you can see that it looks at diseases that are related to physical inactivity and to air pollution. And then it also takes into account different types of collisions. So the model is very sophisticated. It has 800 different discrete data points, and it's a really interesting model and has been adopted by a lot of areas of the country in the years since and has gone through many updates. But at the time we ran the model, we found that we would see at a population level reductions in cardiovascular disease, diabetes, depression, and this was just one of the scenarios. But as you can see, we were projecting that the region could estimate over $1 million, $100 million in healthcare savings because of averted healthcare costs that would not be incurred because folks were getting more physical activity. And in several of the scenarios we ran, it was really apples to apples, where the healthcare savings were on par with how much we were spending as a transportation agency. This was an important tool for us to, again, go to those elected officials and help them to understand that the transportation dollars they were programming have broader implications other than moving cars, that we're really looking at the health and well-being and quality of life of those in our region. So when we're thinking about working together as transportation and public health professionals, really, I think as public health, we can help the transportation industry think about not just how much average daily traffic or ADT or the percent of free flow speed, which is the speed at which cars can typically drive up and down a road, or the level of service, which really rates how well a road works for a vehicle, but not necessarily a pedestrian or a bicyclist. But we can really think about other data that can help us to think more holistically about how to rate the value and the performance of a roadway. So we can think about physical activity rates, the presence of sidewalks, we can look at property tax revenues, we can look at obesity rates, poverty rates. There are different ways that we can incorporate data into our decision-making process. I wanted to just mention a few ways that we are partnering with the Tennessee Department of Transportation. We sit on one another's grant review committees. So we sit on their CMAQ grant review funding, and they sit on our Healthy Built Environments grant review committee. We share health data. So many of the state departments in Tennessee have started incorporating health data as part of their grant applications for various grant programs, which is fantastic. We also have 4 different areas where we're looking at research. We're looking at pediatric asthma along high volume roadways. We're looking at transportation access to cancer treatment centers. We're also looking at transportation access to substance abuse treatment for opioid addiction. And then last, we're looking at multimodal cross risk factors. This is a project that TDOT just kicked off. And for my last slide, I would like to just plug a new committee. The Transportation Research Board created a new committee on transportation and public health. It was started this spring, and there are a variety of ways that you can get involved: reviewing papers, assisting with social media and communications, contributing to the strategic planning. We are advancing some recommendations from a conference that happened last December, the Conference on Active Transportation and Health. We are looking at proposals that we're hoping to forward from the research roadmap for transportation and public health, of course, the premise of this webinar. And then we're also looking to promote the Connecting Transportation and Public Health Guide, which is a really robust and well done guide about how transportation and public health can meaningfully partner together. So with that, thank you so much. It's been a pleasure to be here with you today.
Thank you so much, Leslie. Enjoyed learning about all that work and lessons for others in the audience. I'm sure there are plenty. We keep having some questions coming in, but I encourage everyone to continue to send those. We're going to hold that discussion period at the end, so please send your questions in as you have them. We're going to turn the stage now over to Katie Harmon to continue our presentations. Perfect.
Thank you, Dan. Does everything look okay?
It looks great.
All right, thank you. Well, I'm Katie Harmon, and I'm a research associate at the UNC Highway Safety Research Center. And thank you for joining us today. Today, I'm going to be presenting some information about data linkage and integration and how linking data can provide valuable information from transportation safety planning. So I will start with some background information, but before I do that, Dan is going to launch a poll question in order to gauge your experience with data linkage and integration.
Okay, Katie, you probably can't see it because you're presenting, but we're asking everyone to share your perspective and your experience. So the question reads, which statement best describes how you're feeling about health data integration in surveys? So maybe you didn't know this was a thing. You may not think your community is ready for, or maybe your community is not already doing this. You may feel ready to learn more, or maybe you've been doing this for a while now. We like to hear about that too. So I'm gonna, I'll keep an eye on the number of people who have voted, and when that starts to level off, Katie, I'll close the poll and we can show the results to everybody. And I'll read them out for you too, because you won't be able to see them.
Yes. Do you want me to continue on my presentation or wait until we have more responses?
It won't take much longer, so let's keep the poll open, maybe 5 or 10 more seconds, and then we'll turn around and see the results.
Wonderful, thank you.
Right, get those votes in. We've got about 2/3 of you all have voted, so a few more seconds, and then I'll close it up. Okay, I'm going to close the poll now, and I'll share the results. So Katie, for your knowledge, 74% of the votes that came in said, "I'm ready. I feel ready to learn more." 16% said, "I had no idea this was a thing." 15% said, "I don't think my community is ready for or is doing this." And 7% said, "I've been doing this for a while now." So that's encouraging as well.
That's really encouraging. Well, I'm excited to talk some more about data linkage and integration, hopefully convince those who don't think their community is ready for this that I think their community probably is ready, although it may be challenging. And I'll continue on through presentation. Hopefully we all learn some things. So to start with some definitions, data linkage is defined as a process of combining information believed to be related to the same person from 2 or more separate data sources. Data linkage differs from data integration, which is the ongoing systematic linkage of data sources for the purpose of improved research, program management, evaluation, and policy development. However, these terms are often used interchangeably. So for my visual learners, this first figure displays an example of data linkage, in which crash data is linked with EMS data as part of a single one-off linkage. This second figure illustrates data integration, in which crash data is linked to EMS, insurance claims, death certificate, emergency department visit data, hospital discharge data, and trauma registry data on an ongoing continuous process. And this may seem a lot, but some states, such as Maryland and Utah, are actually integrating many, if not most, of these data sources. To give you an example of how linking data can provide a more complete picture of a motor vehicle crash injury event, I will describe a hypothetical linked crash patient record. First, you have your crash information. And based on the crash data, we learn that the incident occurred at 8 p.m. and that the person injured was a pedestrian with a suspected minor injury as assessed by the investigating law enforcement officer. In addition, we learned that the incident occurred at a marked crosswalk, that no alcohol test was performed, which is not unusual among pedestrians, and that the striking vehicle type was an SUV. Next, you have your linkage variables or common identifiers between the two data sets. These are the variables that we use to match the crash with the patient record. And in this hypothetical example, we're using the individual's name, their date of birth, and their zip code of residence to link the two records. So from the health data, we learned that the pedestrian had a fracture of the base of skull. This is a potentially life-threatening injury, certainly not a B, suspected minor injury, that the investigating police officer may have missed because it is often an internal injury with no external signs. We also learn that the pedestrian had a blood alcohol concentration suggesting impairment, as well as type 2 diabetes, a condition that could complicate recovery and lead to a worse health outcome. Finally, we learn that the pedestrian was admitted to the hospital and had charges of $95,000, which is not an amount that I made up, but was actually the mean US hospital charge for a skull fracture in 2010 dollars. Some of these incidents can be very expensive, and that's just in medical charges, not taking into account, say, work or disability costs. So now I will shift gears a bit and discuss our North Carolina Crash Injury Surveillance System, or NCSIS. This slide provides an overview of our project timeline. Starting in year 0, our first funded data linkage project was just a pilot project in Wake County, North Carolina, in which we linked crash, EMS, and emergency department visit data. We leveraged the success of this project into expanding statewide linkage with funding from the North Carolina Governor's Highway Safety Program, the Collaborative Sciences Center for Road Safety, and the Centers for Disease Control and Prevention. In the current year, year 5, we are moving beyond linkage to focus on activities related to project sustainability, such as developing a research advisory board, developing a public-facing data dashboard, and developing a sustainability plan. And I want to thank Ann Dellinger for mentioning the Core SFIP program, because that is the program through which we got money from the CDC to move forward with statewide data linkage. It became apparent early on that we couldn't do data integration alone. During the first year of our project, we didn't spend any time working on data linkage. Instead, we spent the first year simply building a group of stakeholders consisting of data owners and users from public health, transportation, and community groups at both the state and local level. In order to successfully integrate data, you need buy-in from both the transportation and public health communities. To maintain a relationship with our stakeholders, we hold annual facilitated half-day meetings in which we provide updates, receive feedback, and brainstorm activities for the following year. In North Carolina, we have linked or in the process of linking all the data sources shown on this slide. These include emergency medical services data, trauma registry data, hospital encounter data, which is what we call our linked hospital and emergency department discharge data, death certificate data, and Medicaid data. However, we are only integrating emergency department visit and death certificate data with crash data on an ongoing basis at this time. We have explored several, and I'll talk about some of my linkage methods. We have explored several different linkage methodologies and identified different strengths and limitations with each method. These methods included hierarchical deterministic linkage, recursive partitioning trees, probabilistic linkage, and manual review. And we did use the links guide as part of developing our methods for linkage. Hierarchical deterministic linkage matches records using a set of predefined shared identifiers over multiple passes or cascades. For example, in the first pass, we link records based on, say, date of birth, sex, and zip code of residence. In the next pass, we would link unmatched records based on age, sex, zip code of residence, and race ethnicity. We also incorporate fuzzy matching into hierarchical deterministic linkage by allowing certain variables to flex, such as allowing records to match an age plus or minus 1 year. However, in linkage passes with fuzzy matching, we are stricter with our other matching criteria. 10 or more linkage passes may be necessary to adequately link records. In the interest of time, I will not go into the other linkage methods displayed on this page, but we decided on hierarchical deterministic linkage because we found it was fairly easy to explain to our stakeholders. It can be implemented fairly quickly using a variety of data management and statistical programs, and it yields strong results that are comparable to the other methods displayed on the screen. So now again, I'll shift gears a bit, and I will discuss selected project results. I will focus on pedestrian injuries and fatalities because that is my primary research interest, but we have linked records for all motor vehicle crash road user types as part of our NCSIS system. One reason that I'm so interested in pedestrian injuries and fatalities is due to the changing trends in our state. For example, in North Carolina, the pedestrian fatality rate has increased by more than 50% since 2009. And I know that many other states across the US have experienced similar upward trends. Before diving into a discussion of linking crash and emergency department visit data, I just wanted to advocate for linking to death certificate data. Since we have FARS, which is a fatality analysis reporting system, you may think that linking to death data serves no purpose. However, we found that our death certificate data contains several variables of interest that are not contained in the crash or the FARS datasets. For example, North Carolina death certificate data contains a variable for veteran status. Using this variable, we learned that while veterans make up 11% of North Carolina pedestrian fatalities, they make up only 9% of North Carolina's population. However, deaths are only the tip of the iceberg. In North Carolina, we estimate that for every pedestrian fatality, 7 to 10 pedestrians are treated in the emergency department. For the remainder of my presentation, I will share results from my Collaborative Sciences Center for Road Safety funded research looking at health outcomes among pedestrians treated in North Carolina emergency departments after being injured in police-reported crashes during the period October 1st, 2010 and September 30th, 2015. An important first step before linkage is always examining the frequency distributions in your data sets of interest. Through examining the demographic distributions in our crash and emergency department visit datasets, we learned that North Carolina crash data underestimated the total number of pedestrian injuries by 32%. Certain groups, such as young adults and males, are especially underrepresented in the crash data. It is important to note that some of the additional emergency department visit records are likely due to non-reportable events, such as collisions with non-motorized vehicles, collisions on non-public trafficways, etc. Nevertheless, we have supporting evidence that certain groups of injured pedestrians may be less likely to have a crash report than other groups. We found that 50% of our pedestrian crash records linked to emergency department visit records for a total study population of 6,919 injured pedestrians. We were unable to link records for pedestrians who died at the scene or in transport to the hospital. In addition, we were unable to link information for pedestrians who are uninjured or did not seek treatment for their injuries at a North Carolina emergency department. We also were unable to link records for patients with incomplete or missing personal information. However, we were able to link information for pedestrians who were treated and released from the emergency department, hospitalized, or died in the facility after discharge. Using the cost of injury reports tool developed by the National Center for Injury Prevention at the Centers for Disease Control and Prevention, we were able to estimate the medical costs associated with North Carolina pedestrian injuries and deaths for the study period. Using this tool, we estimated that North Carolina medical costs were $20 million for pedestrians treated and released from the emergency department, $65 million for hospitalized pedestrians, and $9 million for pedestrians who died from their injuries. Note that medical costs are relatively low for pedestrian fatalities because so few survive long enough after the collision to incur medical costs. However, medical costs are dwarfed by work loss costs associated with these injuries, with combined medical and work loss costs totaling more than $1.5 billion for the 5-year study period. In addition to estimating costs, another benefit of linking crash and healthcare data is that you can calculate the incidence of pedestrian injury-related emergency department visits. This first figure displays counts of pedestrian injuries. When we flip to population-based rates, we notice important differences. Among pedestrians involved in police-reported traffic crashes in North Carolina, emergency department visit rates are highest among males, youth and young adults 15 to 24 years of age, and among Blacks and African Americans, who had ED visit rates more than 3 times that of whites and Caucasians. Through linkage, you can also examine the types of injuries observed among injured pedestrians. In this example, I've displayed the frequency of certain types of injuries by age group. One thing that you may notice is that the frequency of fracture increases with age, with more than a third of pedestrians 65+ years of age being diagnosed with fracture. The frequency of open wounds and amputations also increases with age, while the frequency of superficial wounds and contusions decreases with age. The frequency of traumatic brain injury diagnosis displays a U-shaped pattern, with children and older adults both being more likely to be diagnosed with a TBI. And this is of particular interest because TBIs are associated with sometimes severe patient outcomes and long-term disability. Finally, you can examine the relationship between crash characteristics and outcomes using clinical measures that are not based upon the investigating law enforcement officer's assessment. And while I do not want to disparage law enforcement officers, I would generally prefer the clinical assessment of a clinician as opposed to a police officer. Using an injury severity definition based on one by the National Transportation Board, based on things such as, say, the types of diagnoses as well as admission to the hospital, we found that pedestrians were twice as likely to have a serious injury after being struck by a vehicle traveling more than 35 miles per hour as compared to pedestrians struck by vehicles traveling at 0 to 5 miles per hour. I hope that gives you an idea of the power of data linkage and integration. We have many, many more products on our CSCRS R22 and Carolina Center for Health Informatics, Transportation, and Health Data web pages. But before I conclude my presentation, I would like to understand a bit more about what interests you most regarding data integration. Therefore, Dan is going to share a second poll question with you. And like the first one, he'll have to read through the question and answers because I can't see them.
Sure thing, Katie, thanks. So we're asking you to identify just one of these options to complete the sentence. I'm most excited to use linked crash health data to identify roadway injuries not captured in the crash data, obtain better indicators of drug and alcohol impairment, characterize motor vehicle crash injury severity using clinical metrics, characterize long-term outcomes associated with motor vehicle crashes, or characterize the costs associated with motor vehicle crash injuries. So I'm going to wait for some more votes to come in. About a third of you have voted so far. You just have to pick one. You might be excited to do all of these things, but we're asking you to pick the one you're most excited about. Half of you have voted. Let's see when that levels off, maybe 5 to 10 more seconds, and then I'll close it and share the results. All right, we've got about 2/3. That's about what we had last time. So let me close the poll. I'm sorry if you didn't get a chance to cast your vote before I do this. Closing it and then sharing it now. Looks like, Katie, the winner is 39% with identifying roadway injuries not captured in the crash data. The second most, I'm sorry, that was 39%. I can't remember if I said that. 26% said characterize the costs associated with motor vehicle crash injuries. 23% said to characterize long-term outcomes associated with motor vehicle crashes. 12% said to characterize motor vehicle crash injury severity using clinical metrics, and just 1% said to obtain better indicators of drug and alcohol impairment. So back to your slides now, Katie.
Thanks, Dan. That's really interesting. And it helps me like in preparing future materials for presentations and also for our audience members in North Carolina. So before I end, I would like to acknowledge my colleagues from the UNC Highway Safety Research Center, the Carolina Center for Health Informatics, the North Carolina Division of Public Health, the North Carolina Trauma Registry, and the University of North Carolina Injury Prevention Research Center. As I mentioned earlier in my presentation, having a multidisciplinary and multi-organizational team is critical for successful data integration. Finally, I would like to acknowledge our funding sources and display the North Carolina Division of Public Health Data Attribution and Disclaimer, which I have to show anytime I show health data. And here's my contact information, and I will take any questions you have at the end. Thank you.
Right. Thank you so much, Katie, for that excellent presentation. Those costs that you calculated were just staggering. Really shocking to see some of those numbers. So let's leave it there for now. We're going to do those questions, keep them coming in. I'm going to turn it over to our final panelist for the day, Shamsi Sultani. Shamsi, I've got your screen now, and let's see. There you go. Looks great.
Let me just unmute. Thank you for that, and I'm really excited to go after Katie because there are some really clear tie-ins. My name is Shamsi Sultani. I'm a Division 0 epidemiologist for the City and County of San Francisco's Department of Public Health, and I'm going to talk about health and transportation partnership in my city and county. There we go. So this first slide talks about the financial cost of traffic injury in San Francisco. We have in San Francisco about 30 fatalities a year and about 500 or 600 people who are severely injured and go to our trauma center. And we've calculated that that's about $35 million in medical costs alone per year, which, as Katie mentioned, is not the full cost of someone being hurt. But in addition, it means that our trauma surgeons are responding every 17 hours to an injured person in an emergent way. And what was really striking was that when we put it all together, all the different types of traffic injuries, about half the patients that are seen at our trauma center are seen because they're injured in a traffic injury collision. So it quickly adds up. In San Francisco, there is a strong partnership between our municipal transportation agency and the public health department in leading Vision Zero. We co-chair the task force. Public health also is the lead for data systems. We have a lot of expertise in community engagement and education. We help with events policy, and we elevate equity in all the Vision Zero work that we do. Here I wanted to show you our fatality trends in San Francisco. In 2014, we adopted Vision Zero, and we also created a traffic fatality protocol. So we put more store by the case definitions moving forward from 2014. And you can see that our numbers dropped pretty significantly in 2017 and 18. 2017 was the year with the fewest traffic fatalities in recorded history, and that recorded history was over 100 years of data. But unfortunately, numbers are not trending in the right direction, and we know that any death is a death too many. So as I mentioned, we have a traffic fatality protocol. That's a strong partnership between the San Francisco Police Department, the SF Municipal Transportation Agency, and Public Health. And it really helps align these different city agencies on such a key metric that the public is really interested in. I think before this protocol, people would ask for public information from different departments and get slightly different answers, which really causes confusion. So something as simple as coming together as a health and a transportation department on a fatality protocol helps increase transparency to the public. And this is a screenshot of our monthly reporting that's online for folks to be able to track what's going on in terms of traffic deaths in the city. Another big thing that public health contributes to Vision Zero data in San Francisco is trans-based SF. And I encourage you to check out this website if you're at all curious. It's a really rich collection of data sets not just of where the police reported collisions are happening in San Francisco and their relative severity, but all sorts of environmental features of the roadways, where are the stop signs, traffic lights, how wide are the streets, and you can see on the left side just a rich array of data that's available for the public to go through. Another really strong component of our Vision Zero work is VZIPR, the Vision Zero Injury Prevention Research Collaborative. This is a diverse group of epidemiologists, including myself, and my position notably is funded by the SFMTA, even though I sit within the Department of Public Health. But also we work with trauma surgeons and nurses, ER physicians, GIS analysts, and other key staff to really work closely with clinicians in being prepared to advance evidence-based data that will save lives in San Francisco. One of the key projects that this partnership really allows is our transportation-related injury surveillance system. And this is a probabilistic linkage between police collision report data and trauma registry data in San Francisco. And in San Francisco, we have a geographic advantage in a sense in that our city and county has one major trauma center where all the most severe injuries go. So by collecting data from that one hospital, we are able to get a pretty comprehensive picture of who's getting hurt in the region. So why would we go through the trouble of data linkage? I think the prior presenters have done justice to this question, but I want to give just relative strengths of the data sets I'm talking about for San Francisco. Standard practice, as you'll know, as police reported injury collisions. And there's some really strong strengths to that data, including crash characteristics, which way the vehicle might have been going, where exactly the crash happened. But on the flip side, there's relatively light data on the level of injury severity. And we know from the literature that there's underreporting of injuries overall. In our trauma registry data, hospital medical records have a lot of other information besides, they have a lot of other information, including injury severity assessment that is determined by a medical professional, but also, as Katie had pointed out, comorbidities, demographic information, maybe disability status on people who are getting hurt, and environmental information, such as whether someone's experiencing the effects of homelessness. And these are things that we care about because they may be associated with vulnerable road users. To dive in a little bit more on specifically the injury classification, since we have an injury variable in both data sets, how are they differing? We know that the police definition is done from a visual assessment, usually at the place where the injury occurred. And officers are asked to use this kind of assessment of body regions to make their determination of how severe an injury is. On the right-hand side, we can see that the injury severity scale that they use at the trauma center is assessed by a medical professional. They have the advantage to be able to do this a little bit after the crash and really assess different body regions with the help of medical imaging sometimes. So we know that those injury severity assessments are more valid over time. Research shows that. And in general, when we look at both data sets, we are able to say that in San Francisco, globally, the police officer assessment generally underestimates the severity of injury that someone has suffered in a crash. And what else does linkage tell us? So when we look at a subset of our data of those people who were transported to the trauma center by an ambulance, so someone was in a crash that was serious enough, they need an ambulance transport, who's showing up at the hospital that didn't link to a police report, that didn't have a collision report? Of bicyclists, almost 4 in 10 folks who have a severe injury aren't showing up on police reports. And that's a trend that we see in other modes as well. So of pedestrians, it's 1 in 4, and of severely injured people in vehicles, about 28% of people who end up at the trauma center were not in a police report. So with our linked data, what we do in San Francisco is map the collision location and create a high injury network. And you can see that in blue on this map here. So that blue is 13% of San Francisco streets, but it represents the locations where 75% of severe and fatal injuries happen. And just by virtue of the map, I think it's a great illustration that traffic injury is not random, and that because of that, we can work to prevent it. And the other takeaway I think from this slide is that about 60% of the data links between our police and hospital data sets, which means that there's a full 40% that only appear in one data set or the other. Oh, and finally, our high injury network is used by transportation planners to direct capital investments. So I know that we have about $50 million a year invested in improvements that are happening in this high injury network in San Francisco. The other thing that you've seen on that map and this one as well are orange areas. That is what we've dubbed our communities of concern. These are areas of historical disinvestment where there are high, it's a proxy measure of low income, high levels of elderly population, transit dependency, and so forth. So these orange areas that are about 30% of the streets of San Francisco are where a disproportionate amount, 51% of the high injury network is located. So it's a good illustration that we have work to do in the areas that there is historical disinvestment, and that equity lens is important in our work. Along those lines, this is an analysis that Public Health did that focused on seniors and people with disabilities in San Francisco and those locations where traffic injuries are happening. So I want to note that these are distinct populations with some overlap. So in orange, we've mapped the injury segments where these folks have seen severe and fatal injuries in San Francisco. In green, we collected information on where people with disabilities and elders are going in San Francisco. So that includes paratransit pickup and drop-off locations, places where they're getting seen for appointments, senior centers, public libraries, and so forth. And then blue are census tracts where there are high concentrations of those populations. So we saw that within the priority areas in green, 75% of fatal injuries are happening. They're disproportionately on the high injury network again, but also 35% of those areas that we have an intervention that can slow speeds and save lives. So 35% of those streets are also traffic calmable. So this is where data is helping target intervention. I also want to talk a little bit about how our health partnership really prepared us to be responsive to new data needs moving forward. So 2020 is the year of the pandemic, but for us, 2019 was the year of the e-scooter in San Francisco, and I think for many people across the country. You can see here just a selection of sort of media reports on what is happening with e-scooters, are they safe, and we're noticing that there's many deaths. And so there's lots of a public outcry and concern about e-scooters, and not much data to answer those questions with. So what we did with our V-Zipper group at the Trauma Center was develop this sort of visual map with different vehicle type names, so that when you hang this poster in an ambulance or a trauma bay at the hospital, clinicians know that they can put that vehicle type name in the medical record, and we can pull that text out of the medical record to start to get very basic numbers for who is being affected by a traffic injury associated with these emerging vehicle types in San Francisco. We put out a couple of partnership publications based on this data. We described this methodology and shared it because many jurisdictions across the country were grappling in parallel with this issue. How do we track injuries with these new devices? And we wanted to share our methods. And then also we supported the SFMTA by creating an e-scooters collision and injury analysis that informed the Powered Scooters Chair pilot evaluation that SFMTA was heading in San Francisco to regulate e-scooters. Longer term, this work was the proof of concept for a proposal that we collaborated on to the CDC's National Center for Health Statistics to change ICD-10 injury codes so that nationally there would be a data set where folks could track who is getting hurt in transportation collision with micromobility device. And I'm happy to say that that implemented this month, just October 1st, And Katie, in fact, was someone I collaborated closely with to get this proposal out. And it means that there will be really exciting data moving forward. So just to sum up where I've been, where have we seen the added value in data linkage? We think that it gives you more accurate, comprehensive data overall for decision making. It really lets you be evidence-based in the transportation dollars that you're spending and the projects you're prioritizing. And we know that the standard police data alone underestimate injury severity and miss between 24 and 39% of severe injuries alone that are seen at the hospital, depending on mode. And we know that linkage lets us leverage the relative strengths of different data sources. And then more broadly, partnering with public health gives you a different set of advantages. We think an interdisciplinary approach in general is really helpful. And this is a picture of a press conference with Senator Scott Wiener trying to advance the Safe Streets bill. And we had a trauma surgeon speak based off of her expertise to support this sort of policy moving forward. And we know that clinicians are respected sort of speakers in our society. In addition, we know that public health helps us understand vulnerabilities that inform targeted policies, particularly when we're talking about folks most vulnerable on the streets. And I showed you an example of folks with disabilities, but also we think increasingly about people who experience homelessness, who are more impacted by traffic injury on the streets. I also want to acknowledge the huge amount of partnership that it takes to do this work that we do in San Francisco, from different city agencies to the ambulance transport folks, as well as the great support and accountability mechanism of our community partners and advocates that make this work at the forefront of city priority. So thank you.
Thank you so much, Shamsi. It was an excellent presentation, and I think it will segue well into our discussion period, which we're going to kick off right now. Let me get my screen up because what I'm going to put here is, in case you can't get your question answered or we don't get to them all, a way to get in touch with our panelists if you like, and our contact information here for general inquiries. So, but let me turn it over to Ann Dellinger. You're going to do the hard work of helping us to facilitate this discussion period.
Triage, I'm going to triage. Okay, so the first question that I think we'll do, because it rolls right along with the idea of connecting public health and transportation, is, do you have any tips for how to identify or find the right person to represent the public health perspective on grant review committees or stakeholder committees? I was wondering if Leslie had any idea about that.
I think that's such a great question. And my answer may be a little bit atypical in that I think sometimes it's great to pull in the non-traditional suspects. So we have gotten pediatricians who focus on immunizations to be part of grant review committees with other state agencies like the Department of Economic and Community Development. And the reason that we do this is because we're looking for folks who have more of that broad systems thinking, and it's okay if they don't have any certain subject matter expertise in an area, but more so we're looking to diversify our workforce so that we have more folks that have that subject matter expertise or who have at least been exposed to the topic. So you can certainly approach, some states have physical activity coordinators, some have chronic disease sections, some have folks that are dedicated to the built environment, but you can also network and just try to find someone who is that broader picture systems thinker and maybe up for something a little different.
Thank you, Leslie. And I have one here for Katie for North Carolina. So the question is, with North Carolina data integration system, what was your experience with trying to work with state social services agencies, including those that provide Medicaid support?
Thank you, Anne. That's a good question. And we actually worked with an honest broker, which is the UNC Shep Center, based at the University of North Carolina at Chapel Hill, to obtain Medicaid data, which comes from our North Carolina Division of Health Benefits. It was a bit challenging in that we had to sign a DUA with SHEPS and the North Carolina Division of Health Benefits, which made the process take almost a year just before we even received the data. And that's one of the reasons I didn't share a lot of results related to this linkage, because we just finished the linkage this past month. So I can only speak from my own experience, but if you do want to link to Medicaid data, know that it can be a complicated process. The Medicaid data contains a lot of very sensitive information, and so you have to meet a lot of requirements before you can gain access to the data. And that once you receive the data, based on what we've looked at so far, it is very complicated. I would almost compare, it's very different from any health data I've used before. I'd actually compare it more to an itemized receipt. So it's not just that every healthcare encounter gets a record, every transaction gets a record. And so not only do you have to link things to the crash data, you have to link all the information in the Medicaid data to certain individuals, which you think would be straightforward because they do have a Medicaid ID number, but it's not, that's not always the case. So there is a lot of value there, but I would I would go into that linkage with an implementation plan in mind before actually linking the data. Thank you, Anne.
Did we just lose Katie?
I'm still here.
I feel like we.
That was.
Oh, okay.
Sorry, that was it. I think I
Okay.
might have muted before I said thank you for your question. But yes, it's a complicated.
Okay,
short answer. It's complicated.
Okay. What health metrics have you found to have the most impact with stakeholders? If we can start with Shamsi and then Leslie or Katie.
Yeah, I think it depends on your stakeholder group. I know that people with disabilities in San Francisco are a group that always want some data-driven information, especially from our linkage. But we also have to contend with the fact that data quality isn't always as good as we want. So, for example, I think there's a lot to be mined in the hospital data sets around the comorbidities, around the disability data. But we also have an OTS, an Office of Traffic Safety grant this year to explore the reasons that some of these variables aren't totally complete in our hospital data set, and try to improve that data over time so that it's not such a small subset when we know that these variables probably affect larger amounts of our hospital records. But in terms of what variables we care about, I think very much the ones that correlate or give us more information about the most vulnerable road users.
Thank you. Katie or Leslie, did you want to add anything, or should we move on?
I'll add. This is Leslie. Oh, go ahead, Katie.
I was just going to add that I agree with Shamsi. It depends on the audience, but costs tend to. A lot of our audience reacts a lot to cost information. Also, if you could ever tie it back to pediatric injuries, is another group that tends to get a lot of buy-in from stakeholders.
And I'll just add that I think over the years, what first captured the attention were the rising obesity rates among children and adolescents more than a decade ago. And then I think what ended up capturing the attention of a lot of the adult stakeholders were the prevalence of diabetes rates. And so unfortunately, most folks know someone who's diabetic or pre-diabetic, and so that seemed to help. And then when we made some of the linkages between air quality and how it exacerbates heart disease and diabetes, that's something that transportation professionals aren't schooled in. They don't learn that in engineering school. Elected officials don't have that as common knowledge. So those kinds of linkages are helpful to paint that broader picture in addition to the injury picture.
Thank you. And this is for any of the three of you who want to pipe in. The question is, Are there obstacles to accessing the EMS ED data due to HIPAA laws?
This is Shamsi. Yes, we always get this question when we talk about linkage. And of course, linking to health data means that there are HIPAA protections. For my work, I work in the public health department, and so I have HIPAA clearance to work with the data. And also, anytime that we release a subset of the data, we have to get it vetted to make sure that it's aggregated enough to not de-identify anyone. But still, there's huge benefit to reporting, even in aggregate, what's happening to different groups in San Francisco on the streets. Does that make sense?
Yes. Did Katie or Leslie want to pipe in, or should we move to the next question?
Well, this is Leslie. I'll just give a shout out to our team at the Tennessee Department of Health, who actually this week, 2 days ago, did an hour-and-a-half presentation on the hospital discharge data system that we have, how to use the data, how to submit data requests, how to discuss data needs. And so our department is trying as hard as we can to make this data accessible. And of course, we also have to de-identify the data, but there are so many uses for this data, and we have such a strong partnership with our Department of Transportation and our Department of Safety, where we link this data with crash records. And so we're really proud of how we're working to try to make this data transparent and accessible.
Thank you. And here's another data question. So for either North Carolina or San Francisco data, is the more accurate hospital data on injury severity getting into the statewide crash data set? Without this, it is hard to use the data or rank or prioritize proposed infrastructure changes. Would either Katie or Shamsi like to take that one?
This is Katie. I guess I can take it. The answer is no. It is not part of the North Carolina crash data set that's put out by the North Carolina Division of Motor Vehicles. And I don't think that it will probably ever be. It's also, the crash data doesn't make it into our statewide emergency department visit data sets either. What we have is an integrated data set that we are in the process of making publicly available, but that's we're still in discussion about how we do that in a way that protects the patient and amenity of the integrated data. But it is a challenge to researchers. So it is a challenge to researchers that we cannot, and also to transportation planners, that they cannot be part of the statewide crash data set. Shamsi?
Yes, I was just going to weigh in that for San Francisco, it's similar. Our data doesn't routinely feed into the state data set. However, there is a crash medical outcome project statewide in California underway that does take into account hospital injury, but that's an entirely separate, distinct project.
Thank you. And here's one to any of you. Have any of the panelists studied the practice of agencies assigning fault in a pedestrian vehicle collision, either to the pedestrian, the driver, both, or neither?
I can speak for myself in San Francisco. We don't tend to focus on assigned fault. We do report for our fatalities what's happening, but we don't think that it's generally super helpful in talking about prevention, because it assigns individual blame when we really want to build safer systems overall under the Vision Zero framework.
This is Katie. I agree with Shamsi. We don't really focus that on our data because we're really trying to promulgate a systems approach, and a systems approach makes roadways safer for everyone, regardless of who is at fault, because all of us make mistakes.
Thank you. And this one also for any of you who would like to address this. How can we increase reporting of crashes? what are the reporting requirements for law enforcement and other official responders? I'm very interested in this because my sense was it was state specific, but I don't know if that's true.
From my perspective, we are always going to have people that don't feel comfortable going to a police or, calling in a police officer to report their collision, no matter how serious it might be. So I don't think it's attainable to reach 100% of severe crashes having a police report. I think that's why it's so important that we have to look to these ancillary sources like the ambulance transport, the medical examiner records, the trauma registry to supplement what we have, because no one source is the silver bullet. I know that minority groups, people who are undocumented are a major part of the community here in California. And I don't foresee that we're gonna overcome that barrier of having everyone file a police report.
Thank you. Okay, our next question is, how do you account for underreported population counts when doing projects in marginalized communities? Now, I don't know if that would be best for Tennessee or San Francisco or North Carolina. So you'll just have to volunteer here.
Speak anecdotally, and this is mostly from experience when I was at the NPO and I sat on the State Strategic Highway Safety Planning Committee. I think a lot of the questions that we're talking about now really deal with culture, and a lot of it is culture for law enforcement. And that's something that we did. We worked with our law enforcement training academy in our state to try to help them not only better understand laws regarding bicyclist and pedestrian travel, but also to try and change the perception that everyone is a person, no matter if they're encased inside of a vehicle or not. And that's just such a hard message to get across, that somehow we've unfortunately in our country really prioritized that if you're in a vehicle, you are more important than if you are not in a vehicle. And so it takes a lot of education. And so while the data and the reporting piece is incredibly important, there's also a culture piece to have law enforcement even show up to the scene of a crash of this nature, to have them fill out a comprehensive crash report. The media is also such a big part of this. I still cringe when I see the news media who often does assign fault to a pedestrian, even though that should not be a role that they play. I was interested to see the pedestrian deaths in San Francisco. Unfortunately, in Nashville this year to date, we are at 29, which is exceptionally high for us. And so we are really struggling with this culture piece as well as the data reporting piece.
I'd like to add on. Oh, go ahead.
No, go ahead, Katie.
Oh, it's actually Shamsi.
Oh, go ahead. Sorry.
I just like to add that the data are never going to be perfect in the area that you want to work in. So if you have communities that the numbers aren't showing the full extent of, still start with the press release, the analysis, that accompanies sort of stakeholder engagement to say, we care about this group, this is what we see, what can we do to make the data better? I think it's really analogous to a project we're working on of people with physical disabilities in the hospital data set. We know it's a severe underestimate, but if we start with that group and get input, we can build momentum around improving the quality of the data.
Thank you. And what you've both said is related to this question that I'm going to ask you now, which is, are transportation injuries that do not involve a motor vehicle, like a pedestrian trip and fall or a bicyclist fall, included in your state's data system? So no motor vehicle.
This is Katie. The answer is no. In our integrated data, like when we're looking at just things involved like the health data, we do look at those individuals, but in our state DMV data, If it does not involve a motor vehicle, it is not on a public roadway, it does not make it into the data set, or the final data set that DOT uses. We do collect crash reports that do make it into the data set that aren't categorized as traffic crashes, but they don't make it into official statewide numbers. Chauncey?
Yeah, that's the case in California as well. While we do include those solo bike crashes, for example, in our local data set.
And Leslie, did you want to add anything?
I would think that that information would be in our hospital discharge data set, but right. I agree that I don't believe it would be in the crash reporting data set.
Okay, and our next question, do you have recommendations for including the health and injury costs of transportation decisions and into the transportation decision-making process and analysis of the costs of transportation proposals?
I would say absolutely. I came out of a meeting with our municipal transportation agency directors this week, and we were talking about Vision Zero and how we haven't gotten where we want to go as quickly as we want to go. And the conversation was really about we want to get to zero because we can't afford not to, because we are taking into the account all those costs associated with death and injury that traditionally aren't talked about at that level, I don't think.
Anyone else?
This is Leslie. One of the things I think that transportation and health professions have been struggling with is how do you measure these positive impacts? And in some ways, I feel that we shouldn't have to put the burden of proof on ourselves to demonstrate that there are better ways of running a transportation system. Transportation and public health are both very data-heavy industries, and that's a good thing in some ways, except in a situation like this, where we're trying to, for example, prove that if you build a sidewalk, that obesity rates might go down, or that we might have an impact on air quality. And those things are incredibly hard to measure. And so sometimes I feel that we should try to be shifting the paradigm and flipping the coin, if you will, and trying to put less of that burden on ourselves to prove that the right thing is the right thing. And just, again, more focusing on culture. Stories from constituents go a long way, and ultimately we're trying to influence the decision-making of elected officials. And we know that while data is very important in influencing them, stories are as equally as important. And so sometimes you need both those qualitative and quantitative pieces together.
Yeah, that's an excellent point. Okay, so we're nearing time, but we have one more question. What opportunities for prioritizing pedestrians and pedestrian safety does the disruption of COVID-19 create?
In San Francisco, we've created a Slow Streets program where we have closed off certain residential corridors just with signs. They're not enforced, but it's to create more room for pedestrians to be outside and recreate. And it's been incredibly well received in a way that I don't think it would have been a year ago. So I think that it's sort of a silver lining of this time that people are putting extra focus on the value that they're getting from using their streets in different ways. And we can build on that support moving forward on maybe preserving these programs in some shape or form.
Thank you. Katie or Leslie?
This is Katie. I just again agree with Shamsi. I mean, many of our communities, we've do the open streets where we close down streets to motor vehicles, and I just don't see how after this pandemic everything goes back to the way it was. At least I hope so. We also know from anecdotally that walking and biking is up, and I think that I hate to say anything positive about the COVID-19 pandemic, but I do think that it has an opportunity for pedestrians and bicyclists to also sort of gain more prominence, and that also to hopefully maintain a presence once things start returning to normal. However, at least in North Carolina, and I don't know about Tennessee and San Francisco, we have had some issues around still like motor vehicle crashes involving pedestrians and bicyclists, and we're still investigating the causes for that. So, so there's some good things and then some bad things going on.
Well, and this is Dan. I'm sorry to say that we're out of time, and wonderful job fielding those questions. And Leslie, Katie, Shamsi, thanks for your responses, your excellent presentations. I'm grateful that everyone was able to join us for this today, continue the series. We've got 2 more coming, so if you haven't signed up for October 27th, 28th yet, you can do that. I'm going to be sending some links out, including the registration pages with some more information to you later today. But a big thanks to our panel for sharing their expertise and their perspectives, and thanks to you all for joining us. And we'll see you next time. Bye, everyone.